Okay, I see that people are starting to log in. It's 2:02, so hi everyone. I'm Gabrielle Altit. I'm a neonatologist based in Montreal, the Montreal Children's Hospital, and I will be co-chairing with Dr. Daniel Rios, who is at University of Iowa, these sessions on the foundation curriculum for TNE and neonatal hemodynamics from the Neonatal Hemodynamics Research Center. So it's really my pleasure to welcome you to this first session of the 2024-2025 academic year. Basically, I just want to give some heads up about the format that we will have for this current academic year based on the feedback we obtained from previous attendees. Basically, the trainees and junior faculty will join these lectures as panelists, and you are able to unmute and turn on your cameras to ask questions directly to our session speakers. For the seminar audience that are not part of the panelists, you are encouraged to place your question in the Q&A box so that we're able to ask these questions to our speakers towards the end of the first session. After the first session, there will be a small groups for the panelists that will be just for the panelists. The lecture is recorded, but the Q&A session following the lecture will not be recorded, so feel free to ask any questions that you may have. And there will be a link and a QR code to complete the session evaluation once the lecture is complete. So please fill the evaluation because we do look at it so that we can improve the content and really adapt it so that it tailors the needs of the learners that are part of this session. So I just want to acknowledge the fact that the neonatal hemodynamics and the TNE-NP Foundation curriculum is supported by an unrestricted educational grant from Mallinckrodt Pharmaceuticals. And so with undue notice, I want to present our first speaker of this academic session, which is Dr. Patrick McNamara, who will be presenting on neonatal cardiopulmonary physiology. Dr. McNamara is a professor of neonatology and cardiovascular medicine and division director of neonatology at the Stead Family Children's Hospital in Iowa City, affiliated to the University of Iowa. Dr. McNamara has been, a force in our field and a pioneer of our field of targeted neonatal echo and neonatal hemodynamics. He's the current chair of the PAS Neonatal Hemodynamics Advisory Board and also of the American Society of Echo Neonatal Hemodynamics T and Echo Special Interest Group. And he's the co-director of the Neonatal Hemodynamics Research Center. I think he's inspired many of us and taught many of us in so many ways through his academic session, his research, his generosity in sharing his knowledge and experience, and has contributed to support the care of so many vulnerable newborns across the world. So really thank you, Dr. McNamara, for joining us and sharing with us your wisdom. And I will open up the floor for your presentation.
Thanks, Gabriel. I don't know about wisdom, but I'll try and share some thoughts. Just let me know if you can see the slides.
Yes, but we can see them, and yes, perfect. We can see them well.
Okay, perfect. Okay, so it's very nice to connect with everyone for this afternoon session, the first of the curriculum, and I think this is probably a very good place to start. A lot of the time we get caught up in imaging and who should image and why they should image and et cetera, but the fundamentals of why 20 plus years ago, people like myself really pushed changing the paradigm is what we lacked in the NICU was a physiology-based approach to cardiovascular care. So for the next 30 minutes or so, we're going to talk about why hemodynamics is physiology. So some of you may have seen this paper, and if you haven't, I would encourage you to take a look at it. Kind of that Steve Abman and Phil Levy and I wrote on re-engagement with physiology because there are many existentialist threats to contemporary neonatology, but one of them is how far many neonatologists have moved away from thinking of physiology at the bedside how the approach to care is oftentimes very dogmatic, very algorithm protocol based, and it makes no sense. And what I'm going to talk about today is, what is our ground zero and how can we evolve beyond that ground zero? How can we re-engage with physiology and recognize that it is vitally important to have a fundamental understanding of the principles that govern, the neonate, the immature neonate, if we are to optimize the care of these babies. This has become my new most favorite slide, and I've introduced it to many presentations. And I would encourage you just for 10 seconds to look at the slides and to look at the black boxes and to look at the red text boxes. And think for a second, how many of these concepts or principles have I heard of? Can I relate the principles to the specific physiologic concept? And if I were to do a test today all across the country and get neonatologists to complete this and to draw the lines between these boxes, many people will struggle to do that. And that's a problem because whether you're managing the lung, whether you're managing the cardiovascular system, these principles are vitally important. So what is our ground zero? Our ground zero is really terrifying, okay? Today, in the year 2024, in the vast majority of NICUs across the world, people provide a blood pressure-centric based approach to decision-making. The adjudication of whether you're well or unwell is based on arbitrary thresholds of blood pressure. And what that has cultivated, a symptom-based care approach to management. Second, most of our clinical trials, doesn't matter what the topic is, are trials based on convenience, okay? Can I recruit X number of patients within a certain time frame and make the trial very pragmatic to try to get patients into the trial without actually looking at the applicability, recognizing the broad variance in physiology that may exist within individual patients. And then finally, most people struggle with very infrequent or periodic echocardiography. And when it is done, most of the information provided to the neonatologists are based on an anatomy-based imaging assessment, a protocol that's designed for anatomy that is used to actually kind of provide some physiologic information. And oftentimes that information is very limited. So then it's no big surprise when we look at our ground zero, it's now very good. We have studies like this from Beaubaton, which suggests that, even if you treat low blood pressure, the babies don't do any better and may actually do worse. And that has caused a paradigm shift in some centers where many individuals will never treat blood pressure. It's considered perhaps not important because of the data that we have. And there's two ways to interpret this. Blood pressure is meaningless, or the approach to thinking about blood pressure, to thinking about what it means within individual patients, and a physiology-based approach to blood pressure is missing from our care. And I believe the latter is the more likely situation. Some of you will have seen this slide before. This is Reagan's survey across academic centers in the United States. This is not preterm babies, this is term babies, but there is massive inconsistency even in how we adjudicate what is normal versus abnormal. So if we don't necessarily know what is the standard of blood pressure to achieve, it's very difficult to actually study the impact of treatments for low blood pressure. As mentioned before, in many centers, people practice still in a very algorithmic-based approach. And if your target is to make the blood pressure number go up, okay, these type of algorithms may make the blood pressure go up. However, within this, there are many issues. There are one, if a therapy makes no difference, why do you keep increasing it? And why do you leave it on if it hasn't made any difference and so forward? But the other big issue within this is the fact that, in most centers today, people rarely perform echocardiography for infants who are hypotensive, okay? Again, a very blood pressure-based approach to care is what drives our care. And for some babies, this may be okay, but for many babies, it really doesn't make sense. These systems have evolved because of the lack of proximity to information that may actually help neonatologists make better decisions. So The second and the other important concept is, the adjudication of how reliable is blood pressure as a measure of how well you are, or how does it help you in making better decisions? And both of these babies in front of you were very sick in our NICU, but neither of them have low blood pressure. As mentioned before, most of the care has been based on arbitrary thresholds of mean blood pressure rather than gestational age. So concept number one, blood pressure does not predict cardiac output in a linear manner. Okay, here's some data looking at two measures, two surrogate measures of cardiac output. And what you can see is that the relationship is very nonlinear, okay, such that there are babies that have low blood pressure but have preserved cardiac output that may not require therapy, and vice versa. And more concerningly, there are babies in the NICU that may have a normal blood pressure or even a high blood pressure, but are in a low cardiac output state, and that's not necessarily recognized. So this relationship between low blood pressure or blood pressure and heart function is very tenuous. Just very briefly, just to identify the point, this was an infant born at 34 weeks gestation who was asphyxiated, initially had RV dysfunction, managed with dobutamine, got better, unfortunately had refractory seizures. The infant had new onset hypertension on day 7, okay? Blood pressure was 98/32, but was had low oxygen requirement. The team did do a blood gas and demonstrated that the infant had evidence of elevated lactate with a base deficit. And when the echocardiogram was performed, you can see, although the blood pressure was not low, this infant had fairly significant LV systolic dysfunction. And when you look at the strain, globally was -6. Okay, so blood pressure or low blood pressure is not the only way to adjudicate the health of an infant. So why might this happen? Well, I think it's important to recognize that in the face of low blood pressure or in the face of low flow, as may exist in this infant here, who was potentially in a low cardiac output state first, the body responds to this by upregulating the renin-angiotensin system, which will lead to high levels of angiotensin II and aldosterone, which will lead to significant vasoconstriction. So the hypertension may be causal, but it also may actually be consequential. And I think one of the things that currently is missing in a lot of NICUs is we have prioritized low blood pressure and deprioritized normal to high blood pressure. And oftentimes when the blood pressure is high, people will look for an excuse. Oh, the baby's agitated or the cuff is the wrong size. But it's possible that the high blood pressure may be pathologic. To further emphasize the point, does resolution of low blood pressure mean pathophysiologic recovery? And this was a twin born at 28 weeks gestation who was hypotensive, got treated, and the blood pressure recovered. You can see 47/32, which is normal, but the infant persistently had elevated lactate. So an echocardiogram was performed, and you can see here that this infant had evidence of fairly significant RV dysfunction, and the quantitative measures were very abnormal. So recovery of blood pressure doesn't necessarily mean that the underlying physiology has actually recovered. We transitioned this baby to a more physiologically more approach to therapy with milrinone and low-dose epinephrine, and the infant recovered. So we need to evolve in our thinking. Blood pressure is important. It does mean something, but we need to think beyond just looking at the blood pressure and looking more comprehensively at hemodynamic stability. This study here from Frank van Bel's group emphasizes it quite nicely. And when they looked at the neurodevelopmental outcomes of hypotensive babies, what they found was no difference between the groups. However, the subgroup of infants with low cerebral nears, potentially a measure of poor cerebral perfusion, were the infants more likely to have impaired neurodevelopmental outcome. So we need to potentially not just look for the cause, but also look at other ancillary ways to evaluate the physiology continuously, and the role of NIRS and potentially providing additional supportive information is something we need to seriously think about. If you look at this algorithm here, physiologically, looking at the relationship between blood pressure, cardiac output, and vascular resistance, our research has focused just on this part. Does low blood pressure predict abnormal states of perfusion or abnormal neurohemodynamics and outcomes related to this, without recognizing that you may have variance in blood pressure, variance in cardiac output, variance in vascular resistance and autoregulation that may exist within individual patients and may actually change over time. So looking at one element is probably not going to give us the answer to find the holy grail to what is the threshold of interest. It's not likely to be an individual threshold of any individual metric. We need to think much more comprehensively about the physiology. So this again, this used to be my most favorite slide. It still is kind of a very favorite slide because this is really the holy grail of what we should be doing in the intensive care unit with sick babies. Our goal is to optimize cellular metabolism. And when you change the paradigm to cellular metabolism, you now need to think of oxygen delivery and oxygen consumption. Oxygen delivery is dependent on the adequacy of hemoglobin, lung recruitment, and cardiac output, which is influenced by heart rate, preload, afterload, and contractility. Blood pressure is important, but it is no longer the endpoint of interest. It is a symptom, an additional symptom or metric of cardiovascular homeostasis. And to better provide care, we need to think of all of these in continuum. So let's think about some of these physiologic concepts. Well, step number one is to recognize that the heart is different, particularly in the most extreme preterm babies. And, we have a baby in the NICU at the moment today who we've been taking care of, who's born at 21 plus 0, okay, whose heart is very different. It's very different in its architecture, very different in its functionality. A lot less muscle, the sarcolemma are much more scattered, thereby making it more susceptible to change. It's also important to recognize that, in taking care of these tiny babies, we're taking care of the fetus. So in utero, the heart will go through a series of normal adaptive states, and the normal adaptive state in the fetus is for the myocyte to proliferate. It undergoes hyperplasia, okay? That's really, really important because if we intervene and have, let's say, states of prolonged hypoperfusion to the heart, or we give medications like lots of steroids, particularly at high dose, that will disrupt this process. By turning off hyperplasia, you end up then turning on hypertrophy, which means that you will have a heart that seems normal in size, but intrinsically it's not. It's got less myocytes. It's got less myocardial endowment. And is this part of the reason why these babies grow up to be adults with hearts that are smaller? We've actually got less myocytes there to support the circulation. So what are the differences in the neonate compared to the older child? Well, the first thing, this is the Frank-Starling law, which is the relationship between preload on the x-axis and contractility on the y-axis. And what you can see, unlike the adult, it is very flat unless you're at low rates of filling pressure. Okay? This is important because giving lots and lots of volume in a state of normal preload is not likely to improve contractility. There are some exceptions. The infant who has a malcompliant heart, such as hypertrophic cardiomyopathy, restrictive pericarditis, okay, or infants like a Fontan circulation, which are passive, there may be benefit to having a higher preload to alter the Frank-Starling law. This is probably the most important principle that underpins a lot of what we do in the NICU, which is the relationship of afterload to contractility. Afterload is what you do in the gym when you bench press, when you squat. You place a load on the muscle, and the muscle is only able to tolerate that afterload if it's higher for a certain length of time. Just like we can't squat all day long, okay? Our muscles will fatigue and they will fail. If you look at the image on the left-hand side, which is a study comparing the neonatal relationship to the adult relationship, on the x-axis is afterload, surrogate. On the y-axis is a surrogate of myocardial contractility. You can see that the slope of the line for the neonate is much steeper, confirming that the neonate for the same delta or change in afterload will have a much steeper drop in contractility. So the neonate, because of its immaturity, does not tolerate afterload well. We don't have a lot of data comparing the RV versus the LV. This is a cath lab study, which suggests that the RV on the left, which is steeper than the right, may have intrinsically more vulnerability to afterload. And that may relate to the fact that the fibers are very different in their architecture. And I think you'll get a lecture about that at another date. When is this important? Well, when you're born. When you eliminate the placenta, when the duct closes, there's a change in afterload to both the RV and to the LV. Managing babies with both acute and chronic pulmonary hypertension places an afterload change on the RV. Closing the duct in the cath lab places an afterload increase on the LV. This is the force frequency relationship, which is something that people don't talk about and something that's very unfamiliar to most neonatologists. It's the relationship of heart rate to contractility. And in a normal preserved relationship, as heart rate goes up, contractility will go up. But to a point, you can't have heart rates of 500 and cope. The neonate will fail because tachycardia will lead to suboptimal diastolic filling time, which will ultimately impact coronary perfusion. So extremes of tachycardia will be harmful. But where this is very relevant is when you're giving medications, okay, to try to optimize heart function. If the medication, which does increase heart rate, does not lead to a synergistic improvement in contractility, you end up with this blunted force frequency relationship. Okay, and that's where serial echocardiography and critically ill babies to look at how does the heart respond to changes kind of as you increase your inotrope, particularly those that have a lot of chronotropic effects. This is potentially very bad because now you've had no gain in terms of function, but you've made the patient more tachycardic, which will further compromise coronary perfusion, leading to decrease in perfusion of the heart. This is a study basically looking at the effect of heart rate on myocyte contractility. And as the cycle length decreases, as the patient gets more tachycardic, the older infant has a more positive response in terms of its contractility than the newborn does. So we have to be very careful about persistent or extremes of tachycardia. This is Robert Hooke, and Robert Hooke is famous for Hooke's law, okay, which is looking at compliance. And compliance really is how does pressure change as volume changes. And this is very relevant in the hypertrophic heart, okay, which is poorly compliant. And if you look at the graphs on the top right, looking at how volume changes or how pressure changes with volume, if there's very poor compliance, okay, for a smaller change in volume, but a much higher increase in pressure. Unlike the very compliant heart, whereas volume goes up, pressure changes to a much less significant effect. And this is very, very important in the hypertrophic heart and when we're trying to maintain effective cardiac output, in which you've got restrictive compliance of the heart. The next concept is the Wynne-Kessel effect, which again is something that we really never talk about, but it actually is very, very important. And the Wynne-Kessel is kind of comes from kind of fireman lingo in which the Wynne-Kessel ensures a continuous flow so that blood, which is coming from the pump, doesn't come in spurts. Because when you're trying to put a fire out, you need the water to be continuous. Similarly, from a cardiovascular perspective, when you empty blood out of the aorta, it is pulsatile flow. There's very little diastolic flow. But by the time you get to the vessels, like here, this is a celiac artery, you can see that there's flow in systole and diastole. What the Wynne-Kessel effect relates to is the compliance of the vessels. What it does is it dampens the flow such that end organs do not receive high velocity pulsatile flow that can damage them. It smooths the flow out so that they get flowed more both during systole and diastole. We don't know the relevance of this to the neonate, but it's possible that there may be premature aging in the aorta and peripheral vessels because of many of the things that we do to babies. We just don't know about it. In adults, in particular geriatric patients, if you lose the Wynne-Kessel effect, this is why people end up getting retinopathy of prematurity and kidney disease and so forth. RV-LV interaction is important. This is nicely demonstrated by Anima Solo's study here, showing that the RV and the LV are completely interrelated, that if you have compromise to one ventricle, it may have a secondary effect on the other ventricle. So again, important consideration. So how do we apply these concepts? Well, first, to recognize that the fetal circulation and the postnatal circulation are very different. The PFO modulates brain perfusion. The PDA modulates flow to the systemic circulation, such that after birth, there are major changes in loading conditions that occur. On the right side, preload is reduced as you decrease blood from return from the placenta to the right heart. Afterload also decreases on the right side as pulmonary vascular resistance falls. The improvement in pulmonary blood flow leads to an improvement in preload to the left heart. And on the left side, afterload will increase as you remove the low resistance placental circulation from the left heart. And it's important to remember these things when you're dealing with sick babies. So when you're born, saturations are not 100%. They take 5 to 10 minutes to increase. And that's because there are changes in physiology that occur. It takes time to recruit the lung. PVR will fall, and the RV needs to adapt to the changes in loading conditions. And that doesn't occur, immediately. It takes time. Here's some data from the Abe Rudolph's canine experiment demonstrating it takes up to 2 weeks for your pulmonary vascular resistance to fall. The other important consideration in the early neonatal period is the relationship between PO2 and pulmonary vascular resistance. And what you can see here is that kind of increasing the PO2 well above 60 millimeters of mercury really has very little added benefit on pulmonary vascular resistance. But when you drop your PVR below 50, you can see a fairly significant increase in pulmonary vascular resistance. As mentioned, the RV takes time to adapt. This is some work from Amish Jain's normative data. And you can see compared to 30 minutes versus 24 hours, that both TAPSE and RV strain and FAC increase significantly. So there's an adaptation that occurs, which is kind of interesting because when we look at things like HIE, we look at the preterm babies and we screen them with echo, the RV seems to be the ventricle that's much more vulnerable. That RV dysfunction is much more common in these disease states in the early neonatal period. So important to think about. What about the relationship between pressure and blood flow? So as vessels decrease in their diameter, resistance will increase and flow will decrease. And this is the relationship between pressure and flow. Pressure is flow times resistance with atrial pressure. And whether you're talking about kind of electrics or talking about geology, this has been defined in a very similar manner. How do we understand these concepts? Because traditionally, we oftentimes automatically think that elevated pressure is driven by elevated resistance. And this is a nice case. I don't know why the image is not working to demonstrate the case of an infant who was acutely hypoxic, had an echo at another institution, which demonstrated kind of that the infant had kind of suprasystemic pulmonary hypertension. The baby was given nitric oxide and got sicker, developed severe lactic acidosis. And kind of when the baby came to our center, when we performed the echocardiogram, what we demonstrated was the infant did have suprasystemic pulmonary hypertension, but had high flow, had very high right and left ventricular outputs. And when we went on and further did imaging, we demonstrated that the infant had an arteriovenous malformation of the brain. So important to recognize that pressure is not just driven by resistance, it's also potentially driven by flow. And in this situation here, where you've got a giant vacuum cleaner in the brain, the right to left ductal shunt is important to supply blood to the vital organs. And the baby became anuric because we limited this right to left ductal shunt by further decreasing flow. So important to recognize that elevated pressure may be of resistance origin. These are situations in which resistance is high, flow is low. Drugs like nitric oxide are likely to be beneficial in this situation. However, flow-based situations, you have the opposite effect, in which you already have got adequate pulmonary blood flow, and by further decreasing pressure, you're not likely to have any benefit in these type of scenarios. This is also exemplified. Again, you're going to have a talk on CDH. There are two types of physiologies. The classic resistance-mediated physiology, where you've got a right to left ductal and atrial level shunt, may benefit from drugs like nitric oxide. But the left heart phenotype, in which the oxygenation difficulty results from pulmonary venous hypertension and is exemplified by a left-to-right atrial shunt, is not likely to benefit from nitric oxide. So understanding the nuances of the physiology is vitally important in these particular scenarios here. So when thinking about pressure equals flow times resistance with atrial pressure, it's important to recognize that there are diseases, that may benefit from vasodilators, but may be harmed by vasodilators. We've not talked about the left heart phenotype very much, but that elevated pressure may be driven by resistance, may be driven by excessive flow, or may be driven by left atrial hypertension, like the CDH babies with LV systolic dysfunction. And the disease really requires a much more precise based approach to therapy. Just to end up very quickly, what about shunts? I'm not going to go into too much details, but again, this is the Hagen-Poiseuille principle, which is based on the fact that flow in a vessel must be Newtonian, laminar, non-compressible, and non-accelerating. Flow is determined by the pressure resistance, the diameter of the vessel, the viscosity of blood, and the resistance of flow, okay, as demonstrated here. So when you're thinking about babies with PDA, okay, the care of these babies is not just about a drug to vasoconstrict, but anything that will influence viscosity, pressure gradient, is going to influence flow and potentially modulate whether the ductus is likely to close or not. The problem is we don't have a lot of evidence for the Hagen-Poiseuille principle, okay? Intuitively, carbon dioxide is a pulmonary vasoconstrictor and a systemic vasodilator. Oxygen does the opposite effects. We don't have much evidence, actually, physiology-based evidence, that these things actually do play a major role. It makes intuitive sense based on our understanding of single ventricle physiology. The effect of PEEP on these things, there is some data that it benefits LV transmural pressure, may modulate flow across shunts, but not a lot. And really, we've got next to no information on viscosity. The final thing I want to mention to you is the relationship between the heart and the lung. Okay, traditionally we put things into buckets. Blood pressure, heart rate, and urinary output are the heart symptoms. CO2, low sats, respiratory rate are the lung symptoms. So that when we've got elevated CO2, we will naturally think about lung recruitment, tidal volume. But how often do we think about, is this carbon dioxide elevated because we've got poor RV function or poor pulmonary blood flow? I learned this relationship the hard way. The baby that got referred to us kind of when I was in Toronto, a very sick baby, born at 27 weeks, came to us with severe hypoxemic respiratory failure, had a chest x-ray that was supposedly normally recruited. The PO2 was 12. Nitric oxide and the oscillator were wheeled in like husband and wife. When I actually performed the echocardiogram, I don't know if this is going to play here, I could see a completely empty ventricle. I could not see the pulmonary veins. The flow was extremely limited in the pulmonary veins. And I asked the RT to come and take the baby off the oscillator and handbag the baby while looking at the flow in the pulmonary veins, and it was like a tap that was turned on. Okay, so this relationship between the mechanical ventilator, the dangers of hyperinflation is really important. And that was first described by Stephen Hales back in 1733, when he looked at the horse model and demonstrated a drop in blood pressure during inspiration. So it's really, really important to recognize that what goes on with the lung and what goes on with the heart are completely interdependent. And there's a pressure gradient between the systemic circulation and the right atrium that's important in spontaneously breathing people. When the diaphragm collapses, intra-abdominal pressure increases and right atrial pressure and pleural pressure decreases. But when you actually ventilate a patient and you increase intrathoracic pressure, you will actually limit this pressure gradient from the systemic to the pulmonary circulation, which can be really harmful in patients with RV dysfunction or preload dependent circulations. The other thing that's really important to recognize is that lung inflation has another very important effect on pulmonary vascular resistance and then secondary effect on heart function. So this is the U-shaped curve, which shows that when you're very hyperinflated on the right side here, pulmonary vascular resistance will be increased. I would also argue that when you have a waterlogged lung from severe edema that sometimes you see in these babies with anasarca, the same effect will occur here. And on the opposite, when you're completely de-recruited, pulmonary vascular resistance will also increase. We try to achieve this normal FRC. And these things are also very important, in many of the disease states that we may be harmful. High afterload may be harmful in pulmonary hypertension or RV dysfunction, but a little bit of high afterload or PVR may be helpful in balancing single ventricle patients or patients with PDA shunts. Okay. So I'm going to stop there. I think I'm at my 30 minutes. And I'm going to end with basically, we're at a crossroads. Okay. Trials have failed. 100% of them have failed in neonatal hemodynamics because we've not done due diligence in characterizing our disease states, understanding the physiology, recognizing that if we are to truly make a difference, we have to define the population, understand the disease, do the pharmacology of how drugs work, and then choose outcomes that actually make sense. And then also recognize that there's a whole massive variance in care that goes on that we don't even measure in the trials that may impact our response to therapy and influence our outcomes. It's really, really important that all of you, go back to basics, re-engage with physiology, ask the question on rounds, why are we doing what we're doing? If something's not working, stop it. Try something else. And really, our ethos is, we can provide care, but to provide the best care, it requires enhanced diagnostic precision, careful integration of the relevant physiology, appraisal of therapies. We had a baby on the NICU 2 days ago, profound heart dysfunction. We echoed the baby kind of 3 times within a 6-hour time period to try to refine the physiology, which was very dynamic. So I'm going to stop there, and I would be more than happy for questions.
Thank you so much, Dr. McNamara, for this outstanding review. Definitely the cornerstone of everything we're doing at Bedside, and so important for the audience to incorporate this as we're starting this new year of the curriculum. So I think now we're going to stop the recording and start the Q&A session.